All right, hit record. So, all right, Tim Fearon, you're pretty well known in the manual therapy community, but I know you're familiar with Phoenix, but you're in Ohio today. So, can you tell us about why you're in Ohio and what you're doing these days?
Yeah, I'm in Ohio because the woman who brought me into this world is living here, and she's certainly in her waning decade at 97. And I make as many trips as I can to make sure that I spend a little bit of life with her. Uh, and in Phoenix, I retired, sold my practice. August 31st was my last day in the clinic, and trying to get used to actually not going to the clinic every day. Uh, but I haven't really retired. I see some patients on the side, and I teach a little bit, and it's part of me. So haven't given that up. and just gave up going to the day to day.
Yeah. I gotta be honest. I think this is earlier than I expected you to retire. So I was surprised.
It's earlier than I expected to retire, but it's not earlier than my wife wanted me to retire. Because she's been out for some time and decided that it wasn't nearly as much fun to be retired alone. So I decided I remembered a little bit who I was before I became a therapist that was obsessed with it, and I should rediscover that. So that's what I'm doing.
And it was funny. I'll just for the podcast, I sent you a picture of your mentors, um, Tim McGonigle and Michael Moore, who are still seeing patients when I ran
Yes.
into them at the conference last year. So that was a crazy moment.
Yeah, well, they've always been uber focused, and they don't see as many people as they used to. And they've totally changed how it is they see people, while the younger people carry on really the fulsome physical therapy. Uh, but yeah, those were the first guys who, they were the first mentors who actually continued to just see patients and could actually do what they talked about, as opposed to just talking about what they thought they could do. So Michael and Tim, great respect. I'm happy that they're continuing to go. I thought I would too. And I did. I mean, I'm going to be 71 in July. So
It's coming up.
yeah.
Now, and I know they probably influenced you a little bit for our topic today. We wanted to talk about exercise. They probably had an influence, but can you talk about maybe, I know you're passionate about exercise and integrating that into orthopedic manual physical therapy. Can you talk about why?
The why is. Let me start with Tim and Michael, because you kicked me off there. They were uh, my first push into being actually skillful at what I was doing with manual therapy. They were very demanding. They were Norwegian trained, and anticipated that you were going to do something, you're going to do it well. And so I followed that pattern, and it was all about manual therapy. In the manual therapy, then there was an add-on with training that was really pretty much only for the spine, for the trunk, if you will, and as I got very, very good with doing what I was doing manual, I realized I was seeing some people for the same thing that I'd seen them for before. And I thought, well, you didn't really fix anything. You just ameliorated the symptoms that were occurring at that time, because here they are at the same problem. And then somebody who worked with them, Dennis Morgan, had a rather extensive training in neurotherapy and exercise with Maggie Knott. And he and I were having this conversation about, hey, what's the next step? And he looked me right in the eye and said, if you just understood understood PNF, you would know how to create the functional gains you're trying to get while you're doing manual therapy. So I launched off the deep end to decide, and really, if you thought about PNF as the patterns that we learned in school, then you missed the boat. It's really about the principles and applying it to what we do, and that totally changed everything I did. It went to Nobody came without having a personal responsibility for their own healthcare problem, which invariably turned into exercise. So that might be maybe the first one that I paid any attention to was Robin McKenzie, because the people were compliant with their home program because they took the leg pain and brought it up to the butt, and they took the butt pain and brought it up to the back, and then they got rid of the back pain. Of course, everybody was motivated to do this. But that was just one isolated event where it was clear that, hey, personal responsibility on the part of the owner of the problem was key. So that's what launched me in that direction.
Yeah, it sounds like you just kind of noticed that was a huge component, and maybe you could be stronger in it in terms of how to get people towards more functional recovery that was lasting. What do you think PTs are doing wrong when it comes to exercise?
Well, wow, you opened up the can of worms. Now, you'll get another word in here in about half an hour. What do I think PTs are doing wrong? It's not all the PT's fault. Let's start with that. I spent most of my career, really, at least the last over 50% of it, treating other people's failures. I'm sure there's a whole bunch of people out there listening to this who think, hey, that's what I'm doing. So something's not happening right when you realize that, geez, you know what? This wasn't that hard, but I'm the fourth PT. Why is that? And I think in part it goes back to I'm gonna diss on everybody here. It's the clinician not actually delivering that which they think or they know or they're thinking their way through to that this patient needs. It's the educators who gave them, no fault of their own, what they had to give them. And because they don't do the active exercise with patients, with people who have comorbidities, they don't do that. They don't own that. They don't have the skill set to pass on to the people in school. And then what they've got to do is keep up with the literature. And the literature goes on with they put out what they get. And so it's asking an answerable question. So they ask an answerable question, they put out literature, they don't do it. They don't do it, i.e. the exercise facilitating a patient to be able to do something. Neither do the people in the academic roles. Therefore, the clinician who walks out of school has never really learned how to do it. And here's the terrible thing. It's rare that they see it modeled by somebody that they're going to then go work with and under. So that's what I think they're doing wrong. And then you add in the patients per man hour pressure that the young therapist has put underneath. If they don't prioritize the exercise, which they don't, if they have to push through more patients at a time, what they do is they hand it off to somebody who's supposedly the exercise person in there. Clearly to the patient, what that says is, this isn't meritorious of my time. So I've got an underling here who's going to do the lesser important thing. So I pushed against that completely to make sure that the patients understood that, hey, this is important if you want to have control, if you want to be the one who's in charge of your future health care. So there it is in a nutshell. I put a little blame around on everybody, I think. Okay.
All right. So yeah, I mean, I think you hit, I think, on with your spiel there on a lot of the issues that I've kind of noticed. We have this, maybe a couple years ago, we started that intentional exercise course. And I think one of the things that I noticed that we kind of talked about is even at these like continuing education courses, exercise, which is just this huge component, gets saved to the last day. And then I kind of sometimes even in that last day, it gets pushed a little bit further. And then you have like 2 hours to go over what might be the most important thing for the patient. So, I mean, I kind of know that was why I felt like that was something that we needed to do. How do you think when you're kind of prescribing an exercise regimen for a patient, how do you know when that's the right exercise approach for that person?
I think what you have to do is, like we do in any passive care, the first thing you have to do is assess the person's psyche. right? Who they are as a whole. I mean, I think it's 51% of what we do. If you do the same thing for everybody, you're going to miss 51% of them. But I think you have to decide uh, how they're going to behave, what they're going to do. One of the worst things is overdosing exercise. What a patient always wants, 100% of the time, what they want is amelioration of the symptoms that they're experiencing. So if I think I probably started to do things where I knew that what I was doing passively felt good, but I made them participate. So I make them participate so they're actually working while we're doing the same thing that I knew passively I could change the symptoms, but I made darn sure it was going to be active, right? And if it was active and they associated with what they did, change their symptoms, now they're motivated, just like Robin McKenzie did. So that really, I think that maybe the most undersold art in all of T2, including school, is the psychology of human behavior, right? We don't know anything about it when we're going to school, and that psych class is boring because we just haven't had to manage somebody else's psyche. So if you can figure that part out when you see the patients, and then take them to something that's legitimately going to be helpful. And then I'm a big advocate. I'm a Maitland model thinker in terms of inductive and deductive reasoning. And what we do with passive treatment, you do it with active. And you reassess the patient immediately afterwards so they associate, okay, we did this exercise A, let's call it, and my apparent symptoms beforehand were changed up or down after having done that. If they're down, the patient's encouraged about that, and then they want to listen to you. If you make them worse, everybody knows the result there. Then they don't really want to follow through, and that would be a mistake. The worst thing, I got my teeth in the era where every back patient was handed off the tear-off slip of Williams flexion exercise. And if you were radical, the posterior pelvic tilt was actively engaged. And I mean, you just can't treat people like everybody's a widget. Everybody's got their own little widgets on top of widgets, and you have to modify accordingly. But the basics of exercise, you have some basic principles that if you can get people in the middle of that bell-shaped curve for the majority of it, great. And then you push the others to the extremes when you need to.
Yeah, I mean, it sounds like for low back pain, especially, nobody responds to not everyone responds to the same thing. I think you only have to treat people for like 2 days to figure that out.
But you were a thinker. You just said it to figure it out. A lot of people are just processing. I call them clock punchers, right? And unfortunately, that's the predominance of the people whose patients I saw later. So I have to presume when I pay attention to a class model, if there's 100, well, not 100, if there's 30 people in a class, you can tell the people who actually do it and the people who give everybody the same thing. And that's, it's hard to believe we get paid professional fees, doctoral fees for a non-thought processed exercise dosage.
Yeah. And I think what you said about integrating exercise into the manual therapy also kind of reminds me of, something I heard Greg Johnson say, which is like after every technique, he would do something, try to get some sort of active movement from the patient so that they felt like it was them that did it and not him at the end of it.
I think I started that way. And Greg, of course, has a P&F background, very heavy, also Maggie not trained. And then I got to the point where it was like, no, the more I can get them to do and get the same result, the better. So the inductive and deductive reasoning getting me to a trial treatment hypothesis became, I bet if I can get them to do this exercise to change that functional pattern, that I'll get them to function better, feel better. And so the passive things became sort of, they got pushed to the back, almost the reverse of what you just described Greg would do. At the end, I'd do something to reward them for having participated in their own health at the beginning.
And did you ever have, or how would you, I guess, of course you had this pushback from patients. How did you cope with that when you had it?
Yeah, you get pushback, and the pushback. How you speak to your patients is totally up to you. But my pushback would be sort of like, somebody would say, I don't want to do that. I said, well, did you want to change the problem that you came for? Because that's why we're doing this. And if they came back and they were, I never asked somebody, how's your home program going? I said, hey, show me how you're doing with your home program. And when it was clear that they weren't doing it, uh, and I started to steer them back to it, they were the people that the pushback category would be complaining. I said, did you want me to invest more concern into your health care than you're investing? And that pretty much got people to pay attention. No, yeah, it's not about Tim. It's not about that guy, the therapist. It's about me. Um, yeah, and the other thing is the obvious. Some people, they'll be very happy if they're doing one, and you have to decide, is it okay with me if they just do that one? Will that resolve? Let's take Robin McKenzie. If that resolved and he got them to the point where they no longer had back pain, the hard sell then would be that, hey, now what you got to do is change the environment that allowed you to create this, i.e., your behavior and your physiologic capacity, to sell them on more exercise, in other words, when they weren't symptomatic. And if you oversell, if you give somebody who needs 3, if you give them 8, then good luck. They're not going to even do the first 3. So you oversell. I don't think you even oversell. You give more to the people who come and say, hey, what else can I do? That's the patient that you give more to. But if you get it to be resolved in 1, wonderful. If it's 2, great. I think everybody knows that the literature would indicate 3 is sort of the limit. More than 3, and they screw up 3, 2, and 1 as well as 4.
Yeah.
So,
Yeah, I want to pivot a little bit and talk about
okay.
the future of physical therapy a little. I think most people enjoy that topic, and it's interesting right now, right? So we have a big thing's remote therapeutic monitoring with these home exercise programs. So people have an app they can log in and
Yeah.
register that they did it. There's primary care PT, musculoskeletal ultrasound. When you look at those things in the future of physical therapy, is there anything that maybe you're concerned about or excited about?
I think the answer is yes to both of them. If you look at all, I see the world through bell-shaped, bell curve glasses, right? And so in the middle of it, the vast majority of people, if they did what they should do, first they'd have to know what they should do. If they did that, they honestly don't need us. If they did it and they do it consistently. Those vacuum form, if you will, exercise programs that they can look online and plug themselves into the middle of the bell-shaped curve. Okay, that's going to work for those people, but let's just cut that in thirds and say that's the middle of the Gaussian curve, and the other 2 sides of the other thirds. Those are the people who need guidance, and those things are going to not help that. The middle of the bell is not going to help the people on the curves, right? And it might actually make some of them worse. So they can't do it in an online fashion. Having said that, it's going to be sold. It's already being sold. So now, what happens with the people who really need help and now feel like they've experienced physical therapy, but they haven't, right? As long as we deliver something that's let's say sub-professional, well, then we're going to create an increasing mass of people who just think physical therapy is worthless. On the other hand, the end of my career, I saw the majority of patients that were cash pay, and they're paying because they weren't getting good care in the rest of the medical system. And they were anxious for me to give them exercise. Why? So that they could learn how to do it and stop paying me because they wanted to get better. And so I think those who really develop a skill set, and I'm not dissing manual therapy, because I think you have to be able to have that skill set to get people to be able to do the rehab and the management things that they need to do. So the person who's really genuinely developed a skill in passive intervention, than active management and rehab, those people are going to do just fine. And those are the people we should be, they should be speaking directly to the public because we can make their lives physically much better. And yeah, that's where I want to be. I don't want to be the guy who's giving out tear out and hand out sheets to. Worse yet, go online and pick out unit number 17B, right? I mean, why did you go to college,
Yeah. Yeah. Sometimes I think pretty hard about that stuff. I think you're maybe a good way to end. Obviously, you've trained a lot of physical therapists, fellows in particular. You won the Carlton-Born Teach I Must Award, I think, in 2017, somewhere around there. Do you want to pass on any words of encouragement from Ohio out to PTs out there, maybe earlier in their career?
Yeah, I do. I think really and truly I mean this. This is going to sound maybe a little too Kool-Aid-y, but it's the truth. I think we're extraordinarily lucky. We get to go to work. We have to apply our minds, right? We have to use our bodies. We're not sedentary. We have to engage with the world. And if you're any good at it, what you do is you help a life immediately in front of you, and you do that on a continuum. And what happens? You do that for a career, and you pass that on to their family. It's really a wonderful profession if it's done well. I know a great deal of the people that I know that are very unhappy professionally with a similar investment in education would be doctors and lawyers. Right? The lawyers, the ones I know who are the happiest are those who don't actually practice law. They just use their law degree in some fashion or other. And doctors just don't get enough time. I mean, I'm not saying that you're not gratified if you're a cardiovascular surgeon and you can do things that other people can't do. That's a wonderful thing. But we have that option. We have that availability, provided that you take the passion into the field and pay it forward. But you can't. You will not get. People will not get that gratification if they go in and they clock punch. Going to work to see, looking at the clock, when's my last patient? And then EMRs have made everybody's life much, much worse. But at least it doesn't help the patient or the insurance company either, because all the phrases that are just computer punched in there. I mean, I get it. You got to do it, but get it done. Don't focus on that. Focus on your patients. That's what I would say.
Tim Fearon, thanks for joining us from afar, and thanks for continuing to pass the wisdom on.
Seth, I'll be happy to rejoin you back in Arizona. It is cold and dreary in Ohio in May.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.